Asciminib really is the start of a new era in CML therapy. For 25 years we've had several tyrosine kinase inhibitors that are very effective, but because they target other kinases as well, you tend to get toxicity, which becomes a major limitation. Asciminib, which is a STAMP inhibitor, specifically targeting the myristor pocket, allows us to get very effective kinase inhibition without hitting other kinases, and that gives us much better tolerance. So the ASK4FIRST study demonstrated that asciminib was both better tolerated than the investigator selected TKI and also achieved better molecular responses. I think they're two very important findings from the study that suggest that for many patients, asciminib would be the best treatment at front line. The question about what to do for a patient who's not achieving an optimal response is an ongoing challenge. For some patients who are greater than 1% at 12 months, it may be reasonable to continue their current therapy if you're very concerned about toxicity of the other agents that you might be thinking about. But for many patients today, with a more ambitious focus on treatment-free remission, you would regard being greater than 1% as not an adequate response, and you want to switch therapy to a more effective therapy at that time. Major molecular response is still an important target to achieve, and it's very much a time-dependent target. If you achieve that early, it gives you an excellent chance of going on to achieve treatment-free remission. If you achieve it later, your chances are less likely, and if you don't achieve it at all, that becomes a challenge in terms of long-term disease control. So it's still a very important marker, but so is MR4, which is a 4-log reduction or less than 0.01%. And these are all important targets that we look at along the way towards treatment-free remission. Treatment-free remission, for most patients, there's either an early relapse within the first 6 months, or if not, ongoing molecular remission over the very much long term. We do see the occasional patient who has relapse out beyond 5 years. It's quite rare, but because of that, we recommend continuing to monitor. We continue to monitor every 3 months until patients have 10 years off drug, and after that we become a little bit more relaxed and monitor every 6 months. But we don't know the long-term likelihood of relapse, so I think we need to continue to monitor, at this stage at least, indefinitely. It's very interesting that patients who relapse within the first 6 months of stopping their therapy have a very rapid rise in their level of BCR-ABL, a very rapid relapse, suggesting that there are still very much viable leukemic stem cells that are able, as soon as you stop the kinase inhibition, to rapidly expand. The patients who have late relapse may be quite different. The tempo of their relapse tends to be quite slow, and in that situation it may be a defect of the immune system that allows these cells to slowly recover. But it certainly does appear to be different in the tempo, and therefore may well be different in what's driving it. The Korean Society Hematology International meeting is a remarkable meeting where you get some of the best international speakers coming to the meeting, as well as very, very high-level Korean speakers as well. So it's been an excellent chance to meet with colleagues from overseas, but also meet with several colleagues around Korea that have a major interest in chronic myeloid leukemia. It's certainly a very exciting time in research in the whole of blood cancer. In my particular field of chronic myeloid leukemia, new drugs are coming along, new understanding about how we can improve responses. It's a great time to join a laboratory or join a clinical group and start a mission to improve outcomes for patients with blood cancers and with chronic myeloid leukemia.